Hello everyone. Assalamu alaikum. Today we will speak about prostate cancer part 6. Um, we have a multiparametric MRI of the prostate. This is considered of one of the investigation. Multiparametric MRI may be used to help determine the need for prostate biopsy in men with abnormal PSA or digital rectal examination. The BIRADS system, or known as PERT system, uses prostate multiparametric MRI to determine the risk of having clinically significant prostate cancer. The BIRADS category ranged from 1 to 5, with higher BIRDS or BIRDS category indicate a high risk of prostate cancer and high risk of aggressive prostate cancer. The BIRDS 1 indicate completely normal prostate multiparametric MRI, and BIRADS 1 or 2, the risk of grade group 3 cancer lesion 4 plus 3 is very low, approximately 2%. Therefore, these lesions are rarely biopsied. Also, a clinician may consider biopsy if other factors indicate a higher suspicions of cancer. Not performing a biopsy of PIRDS less than or equal to lesion will miss a grade 2 group lesion score 3 plus 4, approximately 9% of the time. The BIRDS or BIRDS 3, the risk of the lesion score more than or equal 4 plus 3 cancer is approximately 4%. Some clinicians believe that the risk is high enough to warrant a biopsy of all BIRADS 3 lesions, while others believe that the decision to biopsy these lesions should be based on additional testing such as PSA density, PSA velocity, 4K score, and prostate health index, etc. The BIRDS 4 or 5 have this actually. The risk of lesion score is more than 4 plus 3. Cancer is relatively high, at least 13 to 37%. Therefore, most clinicians recommend biopsy of these lesions. This is a PIRADS version 2 category, and this is a lesion more than or equal 3 plus 4, or lesion here we have a lesion score more than or equal 4 plus 3. So apparently that's the BIRADS version 2 category 1 or 2 have lesion 3 plus 4 or group grade 2 or more than 2, 9%. This is a category 1 or 2. The category 3 is 14% in this grade group more than 2 or equal to. The lesion score more than or equal 3 plus 4. It's 14%. And here the category 4, it's 33% in lesion score more than or equal 3 plus 4. Grade group more than or equal 2. And 5, this is the version 5, BIRADS version 2 category 5. Here it's 66% compared with lesion score for more than 4 or equal 4 plus 3. This is for BIRADS version 2 category 1 or 2, less than 2%, and 3, that's 4%, and 4 here, this is the lesion score more than or equal 4 plus 3, it's 13%, and 5, it is 37%. Okay, so this risk finding, this debate regarding the exact criteria that define the clinically significant cancer. So definition of the clinically significant data that include men who had no previous biopsy, or men with previous benign biopsy, or men with previous malignant systemic biopsy. This is a clinically significant. Okay, no previous biopsy, or those have previous benign systemic biopsy, or those have previous malignant systemic biopsy. This is known as clinically significant. So the calculation of PIRADS 3 to 5 with restricted biopsy that target the lesion seen on MRI, and exclude systemic biopsy result with the calculation of PIRDS 1 to 2 include systemic biopsy and if done targeted biopsy. So inflammation and basal cell hyperplasia and high percentage of stroma are all more common in MRI lesions than in normal appearing prostate. In fact, this benign pathological condition may present a suspicious lesion on prostate MRI, producing a false positive MRI. A biopsy naive man, that I mean no period prostate biopsy, prospective study patient's MRI first, and 4M show that the multiparametric MRI guided prostate biopsies reduce the detection of the clinically insignificant cancer compared to systemic biopsy, thus reducing overdiagnosis. Also, multiparametric MRI guided biopsy increased the detection of Gleason score more than 7 cancer compared to systemic biopsy, but the difference was not significant in all studies. Guideline for use of multiparametric MRI in biopsy naive men. American Urological Association AUA 2018 guideline multiparametric MRI imaging can be considered in men with a suspicious BSA level to inform prostate biopsy decisions. European Association of Urology 2021 guideline when screening suggests the risk of cancer, the clinician should perform multiparametric MRI before prostate biopsy. Also, when multiparametric MRI is negative, that's PIRADS less than or equal to, a clinician suspicion of prostate cancer is low, omit biopsy based on shared decision making with the patient. When multiparametric MRI is positive, I mean that PIRADS more than 3, combined targeted and systemic biopsy. Canadian Urological Association, the CUA 2017 guidelines state that the multiparametric MRI should not routinely be used in biopsy naive setting, and in the patients who are biopsy naive, multiparametric MRI followed by targeted biopsy should not be considered the standard of care. The National Comprehensive Care Network, that's NCCN, is known as National Comprehensive Care Network. This is 2021 guideline. It is recommended that the multiparametric MRI should precede the biopsy and the image-guided biopsy technique be employed routinely. The guideline also states that the most expert advocate for combined approach, both targeted and systemic sampling, as some high-grade cancer are uniquely detected using the systemic approach. The guideline for use of multiparametric MRI in men with biliary benign biopsy, that's AUA and SAR 2016 guideline, multiparametric MRI should strongly be considered in any patient with a period negative biopsy who has persistent clinical suspicion for prostate cancer. A case of a specific decision must be made whether to also perform concurrent systemic sampling. EAU 2021 guideline in men whose testing suggests a risk of cancer, the clinician should perform multiparametric MRI before prostate biopsy, also when multiparametric MRI is negative. That's the PIRADS less than or equal to, a clinical suspicion of prostate cancer is high, or perform systemic biopsy based on shared decision making with the patients when multiparametric MRI is positive. That's PIRADS more than or equal 3, perform targeted biopsy only. CUA 2017 guideline in men who had period negative TRUS guided systemic biopsy who demonstrate increasing risk of having clinically significant prostate cancer since biliary biopsy, multiparametric MRI followed by targeted biopsy may be considered. NCCN 2021 guideline, multiparametric MRI with targeted biopsy are recommended after at least one negative prostate biopsy and high suspicious for cancer based on PSA and or biomarkers. Multiparametric MRI guided biopsy technique is also used. Using multiparametric MRI during prostate cancer surveillance. For more details on prostate multiparametric MRI and multiparametric in general, tests specifically indicate for men with prior benign prostate biopsy. When they are suspicious of prostate cancer despite a prior benign biopsy, several tests are approved for use in this specific setting to help better stratify the risk of cancer. This includes urine tests for PCA3 genes, and also tissue-based tests that confirm MADX or MDX and mitotic prostate test, imaging multiparametric MRI, or some of these tests are described below. So we will start by PCA3, that's prostate cancer gene. Prostate cancer gene is performed and this must be done after both DR urine sampling. So prostate examination push prostate cell into the urethra, which are then expelled into the voided urine. So prostate cells in voided urine are analyzed for overexpression of the BCA3 gene. A higher BCA3 score indicates a higher risk of prostate cancer. So BCA3 is not influenced by prostatitis, alpha-5 alpha reductase inhibitors, or alpha blockers, or soblamato, or quinolones, or doxycycline, or sildenafil. All this cannot affect or influence the BCA3 gene. That the BCA3 gene, it might be from 1 to more than 100. If less than 5, that's it's a 12% risk of the cancer. If 5 to 19 is 17% risk of the cancer. If 20 to 34, this is 23% risk of the cancer. If 35 to 49, it is 32% risk of the cancer. If 50 to 100, that it's 45%. If more than 100, so the risk is more than 50%. This is the risk of the cancer compared with presence of this PCA3 gene in the urine sampling after digital rectal examination. So in men with at least one previous benign prostate, we have suspicion to do this. A BCA3, it's FDA approved for men more than 50 with one or more previous benign prostate biopsy, but should not be used in men with a typically small acinar proliferation on their most recent biopsy. So if the patient have atypically small acinar proliferations on the recent biopsy, we will not advise to do BCA3 as investigation. Also, BCA3 is not FDA approved for men that are biopsy naive. So those have a biopsy naive. Some clinicians still use the test in this man who have or men with biopsy naive. Some clinicians they do this. So we will go to the confirm MDX. Confirm MDX is performed on benign prostate tissue from prior biopsy. A cancer can induce molecular change in surrounding benign tissue, a field effect, or a halo. So when a benign core contains a field effect, there is a high risk of cancer near the site from which the core was taken. So confirm MDX measures the DNA methylations of 3 genes, that's GSTB1 or ABC, and RASSF1, or known as RASF1. So this is a 3 gene that's measured by confirm MDX. So the confirm MDX measure the DNA methylation of 3 genes. This is the 3 genes, is GSTB1, ABC, and also APC, and also RASSF1. This 3 gene measured by confirm MDX DNA methylation. The methylation in any of these genes suggests increased risk of prostate cancer near the site from which the core was taken. If DNA methylation is absent, then the risk of is 4% of the lesion score more than or equals 7 prostate cancer and 10% of for any grade cancer. If methylation is present, then the risk of any grade prostate cancer is approximately 3 to 50%. Confirmed MDX is indicated for men with a previous benign biopsy who are benign considers for repeat prostate biopsy. The test can be used in men with a higher grade BIN or atypical small acidofibrillation, ATP suspicious for cancer. If rebiopsy is indicated, then consider performing a systemic biopsy with increased sampling of the methylated regions and perhaps the adjacent regions. We come to mitotic prostate core test, the MBCT. Mitotic prostate core test is performed on benign prostate tissue from a period biopsy. The mitotic prostate core test measures specific deletions in mitochondrial DNA to determine the risk that the prostate cancer may have been missed on previous biopsy. It is similar to confirmed MDX in that it is tested for a field effect and provide information regarding the risk for prostate cancer. Diagnosis and workup. 2013 Prostate Cancer World Congress consensus stated that the PSA testing should not be considered on its own, but rather as part of multivariable approach to early prostate cancer detection. And that's the digital rectal examination, prostate volume, family history, ethnicity, and the risk for risk prediction models can help better risk stratify men period biopsy results. Life expectancy, age, and comorbidity might also consider when deciding on the need for prostate biopsy. This is the end of section 6. We will come again into another section. Bye-bye.